Hi, I'm Peter Schlegel, urologist in New York and an expert in male infertility. And I'd like to share some data on a presentation that was made at the recent ASRM, American Society for Reproductive Medicine annual meeting on treatment of non-obstructive azoospermia. This involved use of the drug isotretinoin. Isotretinoin is potentially of interest in non-obstructive azoospermia because we know that human testis retinoic acid, which is vitamin A levels, are significantly reduced in men with low sperm counts. We also know that isotretinoin treatment has been associated with improved sperm production in at least 2 reports. A trial of treatment was presented at this year's ASRM Annual meeting in October 2024. It involved 27 men treating with isotretinoin 20 milligrams twice a day for 6 months or more. 18 of these men had actual non-obstructive azoospermia, only 2 with Sertoli cell only, and 9 had cryptozoospermia, meaning no sperm would typically be seen on an initial semen analysis, but after centrifugation or concentrating of the sample, sperm could be found for those 9 men. This study was done at a place called the Turek Clinic, and it was presented by Molly Jessup, who's a nurse practitioner there. Out of the 18 azoospermic men that they treated, 7 had previously had a sperm retrieval procedure with sperm found. Only 2 men had a Sertoli cell only pattern. So this is really a highly selected set of non-obstructive azoospermia patients. Remember, 70% or more of men with non-obstructive azoospermia have Sertoli cell only. The 7 men with sperm found during surgery clearly had sperm production. All 9 men with cryptozoospermia clearly had sperm production already before they were treated. And in our experience, most of the men with cryptozoospermia will actually have enough sperm to use for IVF without doing surgery if you just obtain multiple semen samples, something we published last year in 2023. What other results did they have? Well, overall, 8 of the 27, or 30% of the men, had, quote, reliable motile sperm in the ejaculate seen during treatment. For the azoospermic men, 3 out of 18, or 17%, had sperm detectable, whereas for the cryptozoospermic men, 5 out of 9, or 56%, had sperm detectable. ICSI was still required to use these sperm, and there was only 1 ongoing pregnancy in 6 IVF attempts reported. Responders, interestingly, had sperm in the ejaculate at all time points of treatment, after 3 months, 6 months, and 9 months. Those who were most likely to respond had early or late maturation arrest, the condition I talked about in part 1 of this report. 50 to 60% response was seen in those with early or late maturation arrest. It's not clear how many of these men had cryptozoospermia. Interestingly, they had actually done biopsies on 6 of the 9 men with cryptozoospermia, a group of men we usually find don't need to have surgery. They also reported a condition called partial responders, where 19% of the men had no ejaculated sperm but testicular sperm present. Remember, some of the men with azoospermia had already had biopsies that showed sperm. Only 1 ongoing pregnancy with testicular sperm was reported. Side effects were common, with dry skin or chapped lips being universal, irritability in 52% of men treated, altered cholesterol in 19%, and a rash in 15%. The authors concluded that de novo, meaning new spermatogenesis, occurred after isotretinoin supplementation in men with non-obstructive azoospermia and cryptozoospermia. But remember, many of these men had sperm production documented before treatment. They reported that side effects were common and treatable and well tolerated, and that the maturation arrest pattern they concluded was favorable to a response to treatment. In commentary, I would have to say that isotretinoin is certainly an interesting potential treatment. However, this is not for all men with non-obstructive azoospermia. Population treated was not reflective of NOA patients as a whole. This was also not what we would call a high-quality study because there were no control patients. There are no patients who were analyzed who did not have the treatment. You have to compare treated patients to untreated or control patients to have a high-quality study. Patients were highly selected and often treatable with ICSI without using any medications, which raises a question as to whether there was truly any benefit at all to the isotretinoin that was used. It's important to have high-quality studies to see if this is actually an effective medication. Can isotretinoin help any of our patients? There also are safety issues. There is a critical need to avoid potential exposure to female partners because of this risk of birth defects. More data is needed on isotretinoin. It has an interesting mechanism of action that could be of benefit. We'll need to see who can be treated with this agent.